Now I am starting the remaining part of my previous lecture on septic shock. Now the step 6 is initiate the hemodynamic monitoring. For patients who do not maintain mean arterial pressure of more than 65 mm of mercury, in spite of initial fluid administration, central and arterial lines should be inserted under aseptic technique. Further fluid resuscitation should be done according to the principles of early goal-directed therapy. This has been proved to be useful for patients presenting within 6 hours of septic shock. Keep the central venous pressure, that is CVP, 8 to 10 centimeter water and 12 to 15 centimeter of water in patients on ventilator. Maintain the urine output of more than 0.5 ml per kg of body weight by fluid resuscitation. Keep MAP, that is mean arterial pressure, of more than 65 by fluids and vasopressors. Maintain mixed venous oxygen SvO2 more than 70% by fluids by keeping hemoglobin more than 10 gram per cent, blood transfusion, and if necessary, I added dobutamine. Step number 7, optimize the vasopressor use. If the patient remains hypotensive in spite of fluid resuscitation of more than 20 ml per kg of crystalloid or its equivalent, the vasopressor, preferably norepinephrine, needs to be started to keep the MAP more than 65 mm of mercury. Intra-arterial line should be placed in all these patients. Epinephrine should be first chosen alternative in septic shock that is poorly responsive to norepinephrine. Severe sepsis resuscitation bundle, 6-hour bundle, complete tasks within 6 hours of identify severe sepsis. Measure the serum lactate, obtain blood cultures correct to antibiotic administration, administer broad spectrum antibiotics within 3 hours of emergency department admission. In the event of hypotension and or serum lactate more than 4 millimole per liter, begin vasopressors for hypotension not responding to the initial fluid resuscitation to maintain MAP more than 65 mm of mercury. This is also within 1 hour of non-ED admission. In the event of persistent hypotension, despite the fluid resuscitation, septic shock and or lactate more than 4 millimole per liter. Achieve a central venous pressure of CVP more than 8 mm of mercury achieve a central venous pressure, a central venous oxygen saturation, that is SCVO2, more than 70% or mixed venous oxygen saturation more than 65%. At low dose vasopressin, that is 0.03 unit per minute, if the patient remains hypotensive on catecholamine. Vasopressin should not be used as first line of agent for hypotension. Dopamine may be used as an alternative vasopressor agent to norepinephrine. In the highly selected patient at very low risk of arrhythmia and with low cardiac output and or low heart rate. High dose vasopressors should always be given through the central line. All attempts should be made to taper off the vasopressors once the blood pressure stabilizer. Low dose renal dopamine should not be used in managing these patients. Dopamine infusion should be administered or added to vasopressor, if in use, in the presence of myocardial dysfunction as suggested by elevated cardiac filling pressure and low cardiac output. Step 8. Optimize the hemodynamics. If the patient becomes hemodynamically unstable during monitoring, give further fluid challenge 1000 ml of crystalloids or 300 to 500 ml of colloids over 30 minutes. This fluid is given in addition to the maintenance fluid. This fluid is given in addition to the maintenance fluid. Rate of fluid administration should be reduced if the cardiac filling pressure increases without concurrent hemodynamic improvement or if the patient develops signs of fluid overload or decreasing oxygen saturation. Step 9. Identify the source and assess the severity of organ dysfunction. Further investigation should be performed depending on the specific disease state. A specific anatomic site of infection should be established as rapidly as possible with the help of early imaging such as ultrasonography and CT scan. The patient should be transported for diagnostic imaging only when stable and with appropriate monitoring. Now, primary source of sepsis. Pulmonary is 50%, abdomen or pelvis 25%, primary bacteremia is 15%, urosepsis 10%, skin 5%, vascular 5%, other 15%. Close liaison with the radiologist concerned specialist is needed. So far, that is, sequential organ function assessment should be done to stratify the severity of the organ dysfunction. Step 10. Achieve the initial resuscitation sepsis bundle within 6 hours of hospital admission. Time is tissue. So far as sepsis is concerned, and all attempts should be made for the rapid assessment and attainment of early resuscitation goals in a protocolized manner. Step 11. Control the source of infection. Source control measures should be undertaken as soon as possible following the successful initial resuscitation. Exception is infected pancreatic necrosis, where surgical intervention is best delayed. A specific anatomic diagnosis of infection requiring consideration for emergent source control, for example, necrotizing fasciitis, diffuse peritonitis, cholangitis, and intestinal infarction, should be sought and diagnosed or excluded as rapidly as possible and within the first 12 hours after the diagnosis is made if feasible. Remove the intravascular access devices if potentially infected. Step 12. Maintain the glycemic control. Frequent monitoring of blood glucose needs to be done. A protocolized approach to blood glucose management in ICU is recommended in patients with severe sepsis. Commencing insulin infusion when two consecutive blood glucose levels are equal to or more than 180 mg/cent. This protocolized approach should target an upper blood glucose less than or equal to 180 mg/cent rather than an upper target blood glucose greater than or equal to 110 mg/cent. Keep blood sugar between 110 and 180 mg, with preferably with intravenous insulin infusion. Take care to avoid hypoglycemia. Avoid variability of blood sugar levels. Consider steroids in specific conditions. If the patient remains vasopressor dependent after fluid resuscitation, especially if vasopressor requirement is high, hydrocortisone 50 mg 6 hourly or 100 mg 8 hourly IV should be started ideally within 24 hours. This can also be given by continuous infusion for better glycemic control. Close monitoring of glucose control needs to be maintained during steroid therapy. Steroid therapy may be continued till the patient is on vasopressor and gradually tapered off over a week. Replacement dose of steroids should be continued in patients on chronic steroid therapy. ACTH stimulation test is not routinely done. Following the step 14, following the therapies are no more recommended in the management of sepsis. That is, activated protein C, immunoglobulins, intravenous selenium. Now, step 15, achieve sepsis management bundle goals within 24 hours of hospital admission. After initial resuscitation, the focus should be on further stabilization and starting the adjuncting therapy for sepsis, which can be done by attaining the management bundle goals. Severe sepsis management bundle complete task within 24 hours of identifying the severe sepsis. Administer the low-dose steroids for septic shock in accordance with a standardized hospital policy. Maintain the glucose control 110 to 180 milligram percent. Maintain the inspiratory plateau pressure less than or equal to 30 centimeter of water for mechanical ventilated patients. Organ support such as ventilator or renal support should be instituted as and when necessary as per the ICU protocol. General ICU support such as nutrition, stress ulcer prophylaxis, and deep vein thrombosis prophylaxis should be instituted. Thank you. That comes to the end of my lecture.